Kia ora, welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ. Tonight we're talking about triple-negative breast cancer. It's one of three main types of breast cancer, but a bit less common than the others. What makes it different, and how will that change your treatment? Well, that's what we're here to find out, and we have four panellists to talk to you tonight. They'll share their knowledge and experience. Let me introduce you to them. With me here is patient Kirsty McAlpine, medical oncologist Dr. Clement Korenbaum, and nurse Manpreet Brar. We also have a surgeon, Dr. Alex Brown, joining us online from Wellington. Okay, let's get started. First, we're going to hear from Kirsty McAlpine. She was diagnosed with breast cancer 3 years ago at age 45. Kirsty, thank you so much for being here tonight. Tell us a bit about your diagnosis and the treatment you went through and where you are now.
Perfect, thank you. I'm Kirsty. I suppose my story starts in May 2021. I received one of those screening breast screen Aotearoa leaflet asking me to book that I was eligible for a free mammogram. I'm normally one of those people that put myself last and put things that I'll organise that later. However, something actually triggered me to book a mammogram. I booked that on the Thursday and I was very lucky. Oh, sorry, thank you. I was very lucky that basically they had a cancellation and I was able to get in on the Tuesday. While I was there, I had the mammogram. They picked something up. I had very dense breasts, so quite lumpy. So at that time, they decided they were going to do an ultrasound and they biopsied me as well. From there, I went back 10 days later with the news and told to bring my husband. At that stage, I was told I had the best of bad news. I had DCIS, which was a very treatable one. And at that stage, I decided that I was going to go private because I was very fortunate enough to have medical insurance. 4 weeks later, I met with the breast surgeon and had surgery, had a lumpectomy. I had to wait a few weeks for the results for that. And when I turned up, I remember driving with my husband thinking, okay, well, I know it's a good cancer to have. Who would have thought, you could have a good cancer? But I was going to push to have radiation because I wanted to, give myself the best shot. However, when the surgeon spoke to me, she was quite shocked at my results. I had DCIS, but I also had triple negative invasive cancer. We had caught it early, but that meant everything changed. So she said to me that it was a serious type of cancer that would need to go and have further lumpectomy, get the rest of it out. And then I met with my medical oncologist. What did I know about triple negative breast cancer? I knew absolutely nothing. I knew that there was a type of breast cancer, which was the Herceptin one, because of the Breast Cancer Foundation funding and promotion that they had done about getting that funded. But everything else, I didn't realise how serious it was. I was talking to someone the other day about it, and it was like an out-of-body experience when you're diagnosed with this. You're kind of watching yourself and kind of thinking, is this really happening to me? And you then go down your mind goes down a really scary rabbit hole. So I then go into fight mode and decide that this is what we need to do, and that went. What happened next? I had the surgery. I then had chemo. First couple of sessions were fine. I was well equipped to deal with the lethargy, the nauseousness, and a few other things. Unfortunately, I got pneumonia and got that quite severe. So with that, I also got bronchiectasis, which impacted my lungs. So that meant that I was unable to go down the radiation route, as where the tumour was originally. It was right on my chest wall, and they were too scared that it was going to do more damage to my lung. So with an amazing support crew, my medical oncologist, my breast surgeon, we decided that the best way for me to deal with this would be a double mastectomy, because I didn't obviously tolerate chemo very well and I wasn't able to have the radiation. At that stage, Keytruda wasn't really researched enough and we didn't know enough about that. So unlike the other hormone positive breast cancers, I didn't have a back plan. So that was that. I wanted to make sure I had the best shot for myself and for my family. So when we made the decision to do the double mastectomy, I spoke in long depth with my husband and my family and decided that, well, I'm married, I have got my children, that served their purpose, I didn't really need them, and that life and living was more important. Where am I at the moment? I've still got problems with my lungs. I've been taking steroids on and off for the last 3 years. I've developed Cushing syndrome, and that's from the steroids. At the moment, I'm checked by my oncologist every 12 weeks. She refers to me as being high maintenance. I have to agree that I am high maintenance, but I'm very fortunate to have that.
She says that in the nicest
she
possible
does.
way,
She
right?
does say that in the nicest possible way. She says that it's a terrible ploy to come and see her. So yes, so that's there. Where I am now, even with the side effects, I'm doing okay. Breast cancer is like having grief, you know. You ride the waves, there's ups and downs. Sometimes it comes out at, to your left, right. Trying to find out who I am now because, having breast cancer has definitely changed me. Active treatment looks completely different for everybody. Breast cancer journeys are completely different for every person. There's no one size fits all. But what I will say is that I am happy with all of the decisions that I made. With the treatment that I had. And at the moment, my life is a lot slower than it was. I'm still, I like to say that I live in the present, and that I'm more present for my friends and family. I have 2 sayings that I live by, and that is, there's always a positive in every situation. Some days you just have to look a little deeper to find it. Life is still a daily battle, but every day I win. Breast Cancer Foundation for me has been a godsend, and if you've got questions, please ask them because they are so willing to help. And thank you for letting me share my story.
Wow, thank you, Kirsty. That really is quite a ride over the last few years. So yeah, really appreciate you sharing that with us. We're going to hear now from medical oncologist Dr. Clem Korenbaum, who works at Auckland City Hospital. Clem, thank you so much for being with us tonight. Can you tell us a bit about what triple negative breast cancer actually is and what women might expect from their treatment?
Sure. Kia ora, everyone, and thanks Adele and Zara from having me at the Breast Cancer Foundation. And first of all, thanks Kirsty for your story. I think it really highlights the plans we might have in theory when we look after a patient, and then the reality and how to adjust to that, and that everybody's different and that no one size fits all. Absolutely agree with that. We've got a few slides. So I'm a medical oncologist at my Auckland City Hospital. I primarily look after breast cancer patients. So if we want to go back to a little bit of a definition, I think it's helpful as well for myself. As you may know, when we look at breast cancer, we have our pathologists looking under a microscope to try to determine what kind of breast cancer that is. And they look at things and they add colors to the slides and on the microscope to try to understand whether the breast cancer harbors what we call the estrogen receptor, the progesterone receptor, those hormone receptor, which usually means we can use anti-hormone therapy and can be a sign of good prognosis. And also a very important marker, as Kirsty said, is the HER2, which is a sign of aggressivity of cancer, but this is mitigated because we have such good treatments against it. But when you look at what a triple negative breast cancer looks like under a microscope, you can't find any of the estrogen receptor, you can't find any of the progesterone receptor, and you can't find any of the HER2, no brown. So negative once, twice, and 3 times. This is what we call triple negative. And you might think this is a bit odd definition, because we actually don't define it based on what it is, but what it isn't. It's like you want to name a horse and you say it's not a donkey, it's not a mule, and it's not a pony, but you don't name the horse. So this is why we call them triple negative breast cancer, and I think in the future we'll have a better definition of that, because this is a disappointing definition, because it is a mixed bag of very different tumors sometimes, and some behave badly and they have a bad reputation, but some behave okay, and not all are bad players. So historically, and if we look at the large number of patients, who is more at risk? We have data mostly from the US that tell us that having an African American ancestry actually increases your risk quite significantly of having triple negative breast cancer. Also, as you may know, we all have genes in all of our cells called BRCA, and they usually protect us from cancer. But some individual might be harboring a gene that is slightly altered and is not doing the job at protecting us from some cancers. And BRCA1 and BRCA2, those 2 genes, we know that when they are faulty, this increases significantly the risk of breast cancer. Also, we have noticed that triple negative breast cancer affects younger women as well. So being a younger woman, especially when there's no screening, is a risk factor. So what does that look like in New Zealand? This is the data from the register from the Breast Cancer Foundation. And if you look at that top row, you will see that most of the breast cancers are actually not triple negative, and triple negative breast cancer represents roughly 10% of all the breast cancer. So it's certainly not the most common type of breast cancer. Maybe some variation between ethnicities, but the numbers might be too small for us to draw any definite conclusion on that. And when you look at the age at diagnosis of triple negative breast cancer, this is where you see that there's a slight difference in that more younger women are diagnosed with triple negative breast cancer as opposed to older women. So we always say and think that it has a bad reputation because it is more of a sort of a risky cancer. But bear in mind that there is still a very high chance of cure with those cancers. If you look at that little graph, which is from the Breast Cancer Foundation as well, on the y-axis you have the proportion of survival, meaning the people who are alive and well, and it ranges from 70 to 100%, and the x-axis is the time in years. So you will see that the triple negative curve is, yes, it is the one at the bottom, is not as good as the hormone receptor positive breast cancer. Having said that, after 10 years, you see that about 80% of survival means that 80% of the women are alive and well. And we know that the triple negative breast cancer, when they relapse, they tend to relapse quite early on. And when you go beyond that 3 to 5 years after your diagnosis, then you're much less at risk. So that 10 years figures, although it is not the best one, it means that most patients will be cured. How do we make that diagnosis? Like every breast cancer, on symptoms, mammograms, ultrasound, we use MRIs, my biopsy clips, and if we think that there's a higher risk that cancer could spread, then we can use other imaging such as CT scan, bone scans, or PET-CT scans. But as Kirsty told us with her story, it's important to note that because it can affect younger women, sometimes it happens before they reach the age of systematic screening and mammogram screening. So often those cancers are diagnosed on symptoms. Patient would present with a lump, basically. So how do we treat early triple negative breast cancer? So I can't insist more surgery is the treatment, is the curative treatment. If there's only one treatment to remember, it's the surgery. That's the most important treatment. Everything we're trying to do around it is to try and help the work of the surgeon and make the outcome better after the surgery. But surgery is the core of the treatment. We use chemotherapy, there's radiation therapy, usually offered when the breast is preserved. And I hope in the near future we'll have funding for immunotherapy and other drugs called PARP inhibitors. Or if you're offered a clinical trial, it's usually a good idea. It means good care. And as you may know, the main difference between triple negative breast cancer and other form of breast cancer is that you can't use anti-hormone therapy and you can't use those anti-HER2 therapy except in rare exceptions. So a typical treatment sequence for a patient would be, and that's a theoretical plan, and then the life is happening, like, as you said, Christy, would be usually to start with some chemotherapy before the surgery for several reasons, then have the surgery, and after the surgery, there might be some radiation therapy and sometimes more chemotherapy called adjuvant therapy. What might be changing in the near future is that for some triple negative breast cancer, we might be adding immunotherapy before the surgery and after the surgery, and also those medicine called PARP inhibitors in case we find that there's a BRCA gene mutation. So chemotherapy, as you may know, is a big word for many different drugs, which aim is to stop the growth of cancer cells or kill the cancer cells, basically. If we deliver this before the surgery, it's called neoadjuvant chemotherapy, and it has many advantages because, of course, it can make the tumor smaller and facilitate the work of the surgeon. Sometimes the tumor is not even visible at the time of surgery. This is what we call pathological complete response, and maybe we can't find any tumor under a microscope, and it's actually a good sign, a good prognostic signal. And also it can make it easier to preserve the breast if patients want to conserve their breast. It gives information on how that tumor behaves. Of course, if the cancer keeps growing while in chemotherapy, we might do the surgery earlier, and it allows us to tailor the treatment after the surgery based on how well it has worked. After the surgery, this is called adjuvant chemotherapy, and the aim is to really chase any cancer cells that may remain. The common chemotherapy drugs we use in triple negative breast cancer, you might have heard of anthracyclines, that red drug sometimes called the red devil because of the side effects, but we're now getting better at managing those side effects. Taxanes, very important drugs as well. Carboplatin is more and more added to the neoadjuvant chemotherapy, and as an adjuvant treatment after the surgery, we might offer a chemotherapy tablet called capecitabine. Immunotherapy, what is it? That's relatively new in breast cancer, but it's been used for more than a decade in other forms of cancer, such as lung cancer. It's all about helping our normal immune system to fight the cancer. If you look at the little cartoon where you see a tumor cell in pale yellow and a lymphocyte, which is an immune pop cell that we all have in blue, you will see that those two kind of cells that interact, they always sort of talk to each other. And the tumor cell might use what we call a checkpoint, which is like a little signal, in that example, PDL1, that's its fancy name, to tell the immune cell, that's okay, I'm here, don't do anything about it. And the lymphocyte will say, all right, there's a tumor here, but that must be normal, and it will walk away. Using that immunotherapy aims at restoring our immunity against the cancer, and by blocking those checkpoints, the immune cell will actually recognize the tumor as something that is foreign and that we should get rid of. And then the immune system would do this. However, immunotherapy can have side effects. Sometimes that can be long-term, such as attacking yourself, your own tissues, such as your gut, and gives you diarrhea, some of your thyroid, your lungs. So a lot of side effects. And always think that it's still a highly curable cancer. So the last thing we want is people to have long-term side effects from the therapy. So we're trying to balance that out. So it was the efficacy of that pembrolizumab or Keytruda was well demonstrated in a series of studies, and it showed that first thing, it was improving the rate of cancer disappearance before the surgery, but also that it would improve long-term outcome. And the researchers looked precisely at what was happening 3 years after the diagnosis and the treatment. And they could see that when we were using that pembrolizumab on top of the normal treatment, then it was less likely to see a relapse happening. So I think it's a milestone. It's a very promising drug. We just need to work harder on getting it funded for every woman. How about the risk of relapse? So triple negative breast cancer has a bad reputation because of that risk of relapse, and it can travel to other organs. But when you look at the numbers, the risk of a relapse is indeed high, but more so in the first years after the treatment, especially first, second, third year are more at risk. This is why some patient may be, as you say, high maintenance. But what we can see on those curves, you see that black solid line showing us that after 3 years post-surgery, the risk of relapse actually decreases sharply and might be even lower than that of other forms of cancers in the long term. And so once you're out of that risk zone, then you're less likely to see a recurrence. Advanced triple negative breast cancer is a very difficult disease to treat. It can present de novo. It means when the cancer has already spread when we meet the patient, when it's first diagnosed, or it can be a relapse. Of course, the prognosis is quite adverse. We don't know how to cure that disease, really. Nonetheless, chemotherapy is efficient, immunotherapy is efficient, and we're trying to work on funding for that. And there are 2 new important drugs, so keep an eye out for that. One is called, they all have fancy names, sorry. So the first is sacituzumab govitecan, and the other one is trastuzumab deruxtecan. I trained. And they are promising they cannot get rid of the cancer, but it's certainly prolonged the life and improve the quality of life of our patients. So I think the message is, despite that bad reputation, progress is being made. And when you look at the numbers of women with triple negative breast cancer that were alive and well 5 years after their diagnosis, you see the numbers in the early 2000s was about 76%. And 10 years later, 10, 15 years later, it's like a jump of more than 10%. So I think that is very promising. And this tells us that in conclusion, so that triple negative is not very common, and we really need to work on a positive definition, not a negative definition. Yes, it is more difficult to treat, but with localized disease, you have very high chance of cure. Early detection is still the key, but a lot of progress has to be made to treat the advanced disease. So we all need to continue advocacy for access funding to those drugs and changing that disillusion some people may have in regards to that triple negative breast cancer into opportunities for patients. Thank you.
Fantastic. Thank you so much, Clem. That was very informative for everybody. Now we're going to hear from Dr. Alex Brown, a surgeon in Wellington at the public hospital and in private down there. Alex, we really appreciate you joining us from afar. Thank you for joining us. Can you just tell us a little bit about the considerations that you take into account when you're treating a woman who has, or indeed a man who has triple negative breast cancer?
Kia koutou katoa. Yeah, greetings from Wellington. And thank you so much, Clem and Kirsty. Like, it's really great to hear from both of you. Yeah, I mean, how is surgery affected in triple negative breast cancer? Well, ultimately, I think, as Clem's already said, we do like to give chemotherapy before surgery most of the time, because that makes my job much easier most of the time. So the latest European guidelines came out last month, and they've put it very clearly that any triple negative breast cancer over 10 millimeters is recommended to have neoadjuvant chemotherapy. And as Clem said, up to half can get a complete pathological response, which means that when we remove some breast tissue to look at under the microscope, there's no cancer left. And whenever that happens, everyone in the MDM does a little fist pump because it's the best possible outcome. We love it. And so, yeah, so the first thing is there's a much higher rate of neoadjuvant chemotherapy. And that means that we have this longer preoperative sort of timescale with our patients, and we'll meet them for 2 or 3 appointments in between diagnosis and surgery to check how things are responding and discuss options of surgery and try and work out what's going to be best for each individual patient. And so that decision around what type of surgery have is essentially the same as it would be for other types of breast cancer, but with this added element of how things are responding. So the size and distribution of cancer in the breast is going to be a huge factor on what surgery is needed. If you've got one lump in one place that's small enough to remove even at the beginning of treatment, then clearly if it shrinks, then it's going to be even more amenable to breast conservation surgery. If there's a bigger tumor in a small breast, or cancer, little spots of cancer distributed throughout the breast or a wide area of the breast, then we would be thinking about mastectomy unless things respond really well. And then each woman's individual attitudes to those different risks and benefits of the potential for more surgeries versus better certainty and things will sort of guide each woman's decision. And it's important to bear in mind that local recurrence rates are no worse than other types of breast cancer, and if anything, might be slightly better for triple-negative breast cancer. And so what we do to the breast, whether it's a mastectomy or a breast conservation surgery, doesn't alter people's risk of dying of breast cancer. The really key thing here is that uncertainty about what's left. If you can still feel a bit of a lump and an imaging says yes, there's sort of a bit of residual tumor here, that's a good guide that you need to remove at least that area of tumor. But often the imaging says, hey, it's all disappeared, we can't see anything here. So what do? Well, we need to remove enough tissue to assess and make a judgment of how well it's responded under the microscope. Because you can have a few scattered cancer cells still left in that kind of tumor bed. And we need to have a good look and check. So what we'll usually do is at the time of diagnosis, there'll be a clip popped into the cancer. And that little clip tells us where it was, so that when it's all disappeared, we've still got a target to go and find. And so you have a localization procedure. Traditionally, that's been a wire localization. We're moving towards non-wire localizations using various different types of clever seeds that have a little detector on to find them. And so we just need to remove the clip with an area of breast tissue around it, so that can be analyzed under the microscope. Now, it's going to take 10 days, 2 weeks to get the results back from the pathologist. And of course, that might mean, it looks like there is still scattered cells over a fairly wide area, and we're going to need to do another surgery to make sure we've got everything out. Okay. It might be there was still a little bit of cancer left, but it's well clear of all the margins, in which case you're done and can go on with the rest of your treatment, which would likely be radiation therapy after breast conservation surgery. But some women will prefer to have more certainty and will choose to have a mastectomy, even if there's a complete pathological response. And it's all around, as I said earlier, that sort of certainty versus that potential for over-treatment. And then the other really complicated area is what to do in the armpit. So if someone's had lymph glands that look and feel clear at the time of diagnosis, it's very straightforward. We'll do a sentinel lymph node biopsy. But women do get picked up with cancer deposits in the lymph glands at the time of diagnosis. And if you're giving someone 6 months of chemotherapy, there's a good chance that those lymph glands will no longer have any cancer in them. But how can you confirm that without removing them and having a look? And of course, the big worry that we have with removing lots of lymph glands is that there's a higher risk of lymphedema. And we would like to avoid that risk if the lymph glands are healthy. So we're starting to move towards more targeted axillary dissections where we will remove the sentinel lymph glands, and we have to make sure we remove the cancer, the lymph node that we know had cancer in it at the beginning. So people need a little clip popped in the lymph gland as well, so that we can check on that. We don't yet have long-term evidence that that's definitely a safe thing to do, but it's starting to become more and more standard. And those latest European guidelines kind of specify axillary dissection or targeted axillary dissection sentinel node biopsy for patients who've had an excellent clinical and radiological response to neoadjuvant chemotherapy, and even when they had cancer proven in the lymph gland at the time of diagnosis. So hopefully we can spare more women, bigger surgeries. Another important area, as Clem alluded to, is around BRCA gene mutations. I think it's important to bear in mind that most triple negative breast cancer patients do not carry a BRCA gene mutation. And even most people that do have a BRCA gene mutation still don't get triple negative breast cancer. They still get all the other breast cancers at a higher rate. But it's important to bear in mind they're not. It's not like a synonymous thing. It's a Venn diagram with only a relatively small overlap. There is, so BRCA mutation carriers do have a higher risk of new breast cancer, maybe of local recurrence, and so they're the patients where there is some evidence of potential survival benefit from having both breasts removed at the time of a cancer diagnosis. For most women, removing both breasts doesn't prolong survival at all. But it still might be the right thing to do because it means you've done everything you possibly can. You're not going to need to have mammographic surveillance of the other side and things like that. It might be needed for symmetry and things, depending if you're having reconstruction or not, and what type of reconstruction. So there's lots of factors to bear in mind around how you treat the other breast, even if someone is a BRCA gene mutation. And then that's everything I think I was going to say. So I'll look forward to seeing any questions in the comments. Thank you so much.
That's great. Thank you so much, Alex. We'll hear more from Alex during the question time later, but now we're going to hear from oncology nurse Manpreet Brar. Manpreet is an oncology nurse at Auckland Hospital, and she is going to talk to us a bit about the supportive and nursing needs of women with triple negative breast cancer and about what can help you get through that treatment. Manpreet, just go ahead and share your thoughts.
Thanks, Adele. Kia ora. I work as an oncology nurse specialist in Auckland City Hospital. I shall be talking about my role in supporting the patients with triple negative breast cancer. My role as an oncology nurse specialist is to support this patient group when they come for systemic treatment, that is chemotherapy, or if they're undergoing radiotherapy, I do provide support to this patient group, which is different from the role of breast care nurses who support triple negative breast cancers with the surgical management. We try to provide tailored support to patients based on their individual needs. I shall be talking about most of the services that I've been providing being a part of Auckland City Hospital. There might be slight variations in how these services are offered in various oncology centers throughout the New Zealand. We try to engage with these patients right from the start when they come to medical oncology. As my panelists Clement and Alex have talked about, that most of these patients, they are being offered neoadjuvant treatment. So in this kind of a situation, information is things are rushed for these patients right from the diagnosis, seeing the medical oncologist, discussing the chemotherapy and getting started on the chemotherapy. It's a lot of information for them to take on board. And sometimes these patients may need some scans and they need to sort the access for the chemotherapy. So it's a lot of information to take on board. So these patients, they are given our contact details. This is something they do get in Auckland, being given in their first medical oncology appointment, where they can contact a nurse specialist to discuss any questions and concerns that they have later on once they have processed the information, or to engage with us at later stages. We do work as a multidisciplinary team in looking after these patients, including the cancer support team that includes the availability of social workers and psychological support. Patients are referred to social workers if they have some sort of financial constraints that they're going to undergo because they have to start the treatment, take some time off work, or younger patients who have young children and they need some support in managing the child care, or they need some sort of support in processing the wins. And they are also offered the psychological support, especially if they're dealing with emotional aspect of the diagnosis, going through chemotherapy, struggling in managing the side effects being caused by it. And then we do also have our colleagues from the cultural support teams that are supporting and the patients from Maori and the Pacific Island patients and providing the culture-based support. They have their own social workers and the nurses who sort of mediates between the patients and us in passing or discussing any concerns from either side. We do stay in close contact with our breast care nurses, especially in liaising with them when our patients are due to finish chemotherapy so that the surgical planning can be decided or planned in a planned manner rather than avoiding any delays in the treatment. Once these patients, they start the chemotherapy, we try to meet them at their first treatment, provide some education on the side effects, which could be some of these on the graph, how to manage them, and we do empower them with a written information on the side effects that can happen with the treatment, and how they can manage. One of the main side effects these patients can experience is hair loss, which could be debilitating for some of our patients. So we do give them information and help to organize a wig and even inform them about subsidies being available and some other community sports that they can go to, like look good, feel better, support out in the community. We do follow up with these patients after their first treatment to establish that relationship with them so that they feel engaged and comfortable to call us when the need arises. We do direct them to Breast Cancer Foundation page for more information. They can look for organizing the wigs. Once the chemotherapy is finished, then these patients are referred back again to the surgical team to do the surgical management of their diagnosis. And we do sort of empower our patients with the contact details they can contact once they are referred to that service. And we do encourage them to establish a relationship with their breast care nurses and even with their general practitioner. We are still available as a point of contact for these patients, even if they're not coming to see us at any sooner stage because of that previous established relationship with us. And patients are also being educated to be aware of any changes and to recognize any early signs of relapse so that they can seek a timely help when needed. Last but not the least is we do education on survivorship. This is a whole topic in itself and won't be covered in few minutes for me today. But once these patients are finished with their treatment, and as Kirsty said, she still feels life is slow. So that is like a feeling for some of our patients and thinking like where to go from here and sort of adjusting back to their normal life. We do give them some information that is sort of available on Breast Cancer Foundation. There's a thriving booklet to thrive after the breast cancer. And do provide them some information in sort of managing the healthy lifestyles and some support that they can obtain in community, like pink and steel physios are there and green prescription. And then we do have a Cancer Society support being available out in the community that our patients can reach once the treatment is being finished. That's all from me today. Thank you. Thank you, the Breast Cancer Foundation, for giving me this opportunity.
Thank you. Thank you very much, Anne-Pri, for that. We're now going to move on to questions. Now, first up, we've had a couple of comments from people who've been diagnosed with a lobular form of triple-negative breast cancer. Clem, can you just tell us what that means?
Yes. So as we discussed, triple-negative breast cancer can be one word for mixed bag of cancers, and so most of them, they look like they are what we call basal-like because they look a bit like they share features of the base layer of the breast duct, but not all of them. And maybe 10-15% of the triple negative breast cancer will belong to another category, and lobular triple negative breast cancer would be one of them with very distinct characteristics. So, and because it's small numbers, there's not as much research on those lobular, but they can behave differently and sometimes less aggressively than the classical triple negative ductal breast cancer. Yeah.
And one of these ladies with lobular cancer said she's worried about her cancer coming back, about it recurring. Is lobular more likely, less likely?
When lobular, that definition relies on a kind of little protein called E-cadherin that is at the surface of the cancer cells. When it is not triple negative, the lobular breast cancer can be less aggressive, but have a very long-term, even throughout the whole life, risk of relapse, very like 20-30 years after, albeit low. Triple negative lobular breast cancer are very rare. The risk, I would say that there's still that risk of relapse early on, and certainly diminishes after the 3 to 5 years. But being of lobular subtype, it could mean that that risk of recurrence remains a little bit longer as well.
So that's about staying vigilant about things.
Yes, staying vigilant. The best thing is to listen to yourself, for lumps, unusual symptoms that are lasting more than a few weeks, and then that have no straightforward explanation, and keeping up to date with the mammogram, which is yearly after breast cancer, and at least a yearly physical examination. But in most cases, people will notice when there's a relapse by themselves because there's a new symptom that comes in between 2 mammograms with triple negative breast cancers. Yeah.
And in fact, we had a question about mammograms, which I'm just trying to see here, which was about, is it good to also have an ultrasound as well as a mammogram if you've had triple negative breast cancer? Alex and Clem, I'd like to hear from both of you on that.
I think an ultrasound isn't a brilliant surveillance tool. It has its place, but it's not really good enough as a tool just for screening the breasts. It's really good for checking on a problem that either you found or that has shown up on a mammogram. And a mammogram is much better at actually seeing the whole breast. And being, just because it's triple negative doesn't require a different surveillance sort of protocol or anything. I think one of the hardest areas, I think, is actually in dense breast tissue, because in dense breast we know mammograms aren't as effective, and still, our current guidelines still say, you just get a mammogram. I think it'd be, I sort of suggest if people can, looking at some sort of contrast imaging, contrast mammogram, or even MRI scan for very dense breasts, is I think a reasonable option, but that comes with a cost that a lot of people can't afford. So at the moment, really the mainstay is just the mammograms. I think if you have got dense breast tissue and MRI scans and contrast mammograms aren't available, that's when a screening ultrasound by the right radiologist might be a reasonable thing to do. But again, my radiology department in the public hospital would say, oh no, sorry, we don't do that, essentially. Okay. There was actually another little question related to the same thing, which said, what do we, if we've had a mastectomy, what are we looking for local recurrence? And I thought that was a really good question, because I think our whole discussion so far is almost very much around fear of cancer recurrence. It's such a huge thing that that I think we're not very good at dealing with as medical professionals, and I think it's a really challenging area. But essentially, to answer that specific question from the chat, essentially, it's little nodules under the skin, typically like little frozen peas under the skin, or even little red bumps forming on the skin would be the most common things to look for. So if you find a funny little nodule, just think, don't hit the panic button straight away. Take note and think, I think I can feel something there, and just sort of keep an eye on it and monitor it. And if after a few days, or even a week or two, you're thinking, now this really is something, I need to go and see my doctor about it, give your breast nurse a ring, and they'll get you into clinic for a checkup pretty quickly.
Right. Thank you, Alex.
Over to Claire. Thank you.
Thank you. just a couple of messages actually of encouragement and support for Kirsty. So just a couple of people who have been or are going through the same journey, Kirsty, and saying that one lady who in 2019 went through the similar circumstances to you, and is obviously still going strong and had excellent treatment and feeling very positive. And other people who have said, great, stay positive because you're getting through it. That's fantastic. We'll just move on to a couple of questions now about chemotherapy. Clem, what happens if the chemo doesn't shrink the tumour? What's happened?
As we discussed, because we are now trending to give a lot more of chemotherapy before the surgery, it gives us information on behavior of that tumor. So usually this is why we have very regular, quite intense check during chemotherapy. And if after a few weeks of chemotherapy, 2 to 3 cycles, particularly, we don't feel strongly that the tumor is shrinking, or at least completely stable and has stopped growing, because in many patients that those lumps would have been growing quite fast when we see them, and you start the chemotherapy and it just stops growing and it keeps stable, which means that the chemo is active. We prefer to see them shrinking, of course, but the stability is acceptable. But certainly what we do not want to see is a tumor growing while on chemotherapy after a few weeks of chemotherapy. And if this happens, then we just pick up the phone and call our surgical friends and discuss at the MDM for bringing the surgery forward, because as we discussed earlier, the one curative treatment is the surgery. Everything we're doing around that is trying to help the outcomes of that, but to get the patient to surgery is the most important.
Great, thank you. And someone has asked about what's the difference between 6 and 8 cycles of capecitabine when looking at
that's actually a very good question. That's pretty much be very literate. So, as you may know, there's one large study called CREATE-X that tested the addition of capecitabine for those patients who had triple-negative breast cancer, had the chemotherapy, had the surgery, and you could still see some cancer under the microscope on the surgical specimen. And those patients were offered to have capecitabine chemotherapy. And in the study, they said, do what you can, do between 6 and 8 cycles, depending on how people tolerate it, because, life happens. And some people can tolerate capecitabine very well, and for some people, it's a nightmare. So for someone who's really struggling, I would usually not be pushing beyond those 6 cycles, because I know that study is quite comforting in the fact that if you get at least 6 cycles, then you get the benefit. If you can get to 8, good on you, let's do this. But if you can't, I won't insist, because
Okay, thank you. Alex, a question for you. How do you define early breast cancer? And we'll roll into that a question about a 60mm tumor. What do you call that?
So I guess like everything, I think with breast cancer, it all gets pretty knotty as soon as you start digging into the details. I mean, early breast cancer across the body is stage 1 and 2. Locally advanced breast cancer is stage 3, and metastatic cancer is stage 4. So that sounds easy, but then you get down to, okay, so what's stage 1 and 2, what's stage 3, what's stage 4? So as a surgeon, I take the very traditional and anatomical approach where you look at the size of the cancer and the number of lymph nodes involved, and that equates to your stage. So if it's a small or even slightly biggish cancer, but with no nodal involvement, it's an earlier stage. If you've got a bigger cancer with lots of nodes involved, then you're going to be more locally advanced stage 3. And obviously, if it's spread to other parts of the body, then that's stage 4. But then, of course, you start throwing in these sort of clinical stages. So the AJCC, that's the American Cancer Society, has started to include receptor status in part of the staging definitions, if you use the clinical staging system. And then that then just makes it really complicated. So I use an app to put the details in, and or in fact, the pathologists it comes up on the pathology reports as well, anatomical stage, pathological stage, and it kind of tells them both to me, because it's really hard to just work it out. Okay. Now I think being triple negative, that definitely bumps it up a stage for a clinical stage. And Clem will be more au fait with the implications of that than I am, because as a surgeon, I've just got to cut out the cancer that's there.
I use the same apps as you do, because it's very hard because those classifications can change over time, and it's true that they're getting more and more precise. But it's hard to remember all the details. So we all have charts and notepads to help us. But it is true that it sounded a little bit odd to consider hormone receptor positive breast cancer would usually have good long-term prognosis if they are the same size as a triple negative breast cancer, and not taking that triple negative thing into consideration. So it is now being taken into consideration for staging. Yeah. So for a large tumor, more than 5 centimeters, which is triple negative, there is I would treat this like a high risk tumor, and trying to have as much treatment in as possible to reduce the risk of relapse after the surgery.
Clem, we've had a couple of questions from people about whether triple negative breast cancer puts you at higher risk of other cancers, and also someone who noted they've had a cervical cancer. Would that kind of increase their risk or be linked to their risk for breast cancer?
Oh, that is a very good question. So as we discussed, when for people who are harboring a BRCA gene mutation, they are at risk. Of course, they have a very high lifetime risk of breast cancer, and that's the highest risk. But they also, unfortunately, have risk of other cancers, such as ovarian cancer, pancreas cancer, or prostate cancer for male. I am unaware of a strong relationship with cervical cancer, but bear in mind that cervical cancer is a very common form of cancer as well. So you can have it as well. But I am unaware of a strong relationship, like genetic relationship between them. Also, regardless of the BRCA gene status, having a triple negative breast cancer in one breast puts you at risk of having a recurrence in the other breast as well.
Yeah. Right. Yes, indeed. And we've got someone on the webinar tonight who's in that situation. Alex, question for you. I was diagnosed with grade 3 stage 2B triple negative breast cancer in November. Currently doing chemo. Surgery will be in May. Unsure what sort of surgery is right for me. I'm 36 years old.
Yeah, the great question. I think it's a very individual choice. What's really important to bear in mind is that what surgery you have to your breast doesn't impact what's needed for the rest of your body. So I always like to sort of break treatment down into the local treatment for the cancer that we know about, and the whole body treatment in case there's cancer somewhere else in the body that we don't know about. What we do to the breast is the local treatment, and the whole body treatment is for managing the risk that is there, whatever we do to your breast. Now,
saying that having one surgery won't increase or decrease your risk of the cancer spreading somewhere else. Is that right?
Exactly. Now, I guess, like Clem just said, there's that risk of recurrence of cancer or spread of cancer to the other, of a new cancer in the other breast, or local recurrence in the breast if you've had a breast conservation surgery. But those risks are managed by your monitoring and surveillance, and if something happens, it's generally picked up when it's relatively small and easy to treat, and you're less likely to have life-threatening problems from a second cancer than you are from your first cancer. And so really, it'll come down to your own individual attitude to how important are your breasts to you, how do you perceive those competing risks, what do you feel about a bigger surgery versus a smaller surgery. In general, if anyone's in doubt, I advise them that let's take the step up approach. Let's do the minimum surgery we know is necessary, because of course you can always go back and do more surgery and take more tissue. What you can't do is put a breast back that you've already taken off. And no form of breast reconstruction is as good as your natural breast.
Thank you. That's really helpful. Nice comment from Manpreet here, from someone who you have helped, Manpreet, through your journey. And you are fantastic, you and the team. It's great. Clem, a question around someone who is still struggling with low white blood count. a year since surgery and had surgery and radiation and chemo and is still struggling with low white blood cells.
Yeah, so we do. So it depends on what kind of white blood cell, but sometimes it is true, particularly after the treatment, such as AC or FEC, and I suspect the culprit is the C, the cyclophosphamide. Here, we do see people with chronically low lymphocytes. It doesn't seem to affect their immunity. I mean, I don't notice. That they are more prone or susceptible to infections of any kind, if that's the case. And sometimes we're just looking at numbers, and the numbers are low, but patient is well. Yes, so I'm not too sure whether it comes with a higher adverse risk in the future, but certainly I would recommend to keep an eye. There is with the chemotherapy we use at the dose we use, there are very tiny risk of what we call secondary cancer. It means having another form of cancer 10, 15 years after your first cancer from the chemotherapy, and there could be some form of leukemias, and sometimes leukemias can be one of the cells leukemia could be low white blood cells. But if this happens like recently following the treatment, it's extremely unlikely to be that. Yeah. Okay. So just keep an eye on that. Yeah.
There's quite a few questions about people noting that the difference in size of their tumor from when they had their diagnosis from when they go to surgery. Does that mean their tumors are growing really fast, or are they just different measures? What's the story there? Quite common, isn't it, Clem, for a tumor size to be different?
Yeah, so
diagnostic.
if you're having, yeah, absolutely. So of course you would have first assessment with mammogram, ultrasound, maybe MRI, and they will tell you, oh yeah, there's a tumor here and it measures so many millimeters, so many centimeters. And if you're having a treatment before the surgery, that might shrink the treatment or stabilize it. So the measure at the time of surgery can be very different. Yes, absolutely. I have to say, sometimes when patients have MRI just before the surgery, I am always quite amazed by the precision of the radiologist. They say, oh yeah, that's 27 millimeter, and on the pathology report under a microscope, it's actually this, but there could be discrepancies caused by the treatment you might have received. Yeah.
Right. How long do you normally wait for surgery after neoadjuvant chemo?
Good question. You need to have recovered from the side effect of your chemotherapy and be as fit as you can for the surgery. But usually it should happen between 4 and 8 weeks after the last cycle of chemotherapy. Yeah. Great.
Okay. Do you know of many people on sacituzumab govitecan in New Zealand?
We have, so some are having this treatment privately, even if it's not even registered in MedSafe. I discovered that while making the application to Pharmax, not even registered MedSafe. Yes, and having worked overseas before, we were sometime using it. So it is a useful treatment. It has its own side effects. I can't say it's an easy treatment to go through, and usually patient needs a good amount of support, particularly when it comes to the side effects linked to the gastrointestinal tract. Diarrhea, nausea can be really an issue for patients to continue on this treatment. So I think if we are lucky and we get the funding, the public funding in New Zealand, we'll need to be very cautious in supporting the patients very well, especially in regards to gastrointestinal side effects. Yeah.
Right, thank you. Someone's asked about where we're at with lobbying for Keytruda, the immunotherapy that Simone was talking about.
Yeah, so I just checked this on, you can go on, if you go on the Pharmac website, which is actually a good website, there's something that in Google application tracker, you can track where things are at for each drug, and you will see, so Keytruda is used in many different kind of cancers, and you will see that it's ongoing. So they say ongoing review. It's painstakingly slow. Sometimes I wonder, the drug has been around for 10 years. It's approved in many countries. Why does it have to be so long? But New Zealand has its own way. They want safety first, which is understandable. But sometimes you would really wish that would go a little bit faster.
And we do know it was discussed. We're expecting minutes of the latest Pharmac meeting in the next few days. So we'll see if there's maybe a next step in that process happening. But as Clem says, it is quite slow. Please do call our nurses. They can help you and steer you through some of those treatment decisions along with your nurse and your doctors and help you find support that you need. So please, the numbers on the screen there, do get in touch with us. I just want to say a huge thanks again to Kirsty, Clem, Alex and Manpreet for joining us tonight. So thank you again and good night.
Thank you.
Night.
Thank you.